Hello and welcome to our presentation Exploring Local Policy Context for Reducing Health Inequalities in Children and Young People, an in-depth qualitative case study of one local authority in the north of England. My name's Hannah Fairbrother and I'm a co-lead on this study. I'm at the University of Sheffield. Other contributors to the project are Ellie Holding and Katie Powell at Sheffield, Jonathan Wistow, Naomi Griffin and Carolyn Somerville, all at Fuse. So in the presentation today, I'd like to very briefly talk you through our study aims and our methods, and then focus in on our findings and what we see as the main implications of our study. So, our study is set against the backdrop of rising inequalities in children and young people's health in England. And our study sought to explore, from the perspectives of key local stakeholders, anticipated pathways through which health inequalities among children and young people might be reduced, and also key factors affecting the development and implementation of policy to reduce inequalities among children and young people at a local level. So, in terms of methods, we employed a qualitative case study of one local authority region in the north of England, comprising semi-structured interviews with key stakeholders with a responsibility for child health, non-participant observations of key meetings where decisions around child health are made, and also a review of local policy documentation. Our study was guided by Backey's 2009 What's the Problem Represented to Be framework, and this allows us to explore how inequalities are conceptualised as a necessary precursor to understanding the proposed pathways for reducing inequalities. And in seeking to understand how policies are expected to work, we also employed Pawson and Tilley's 2004 realist approach. We also drew on Head's three lenses of evidence-based policy formulation, and that's political knowledge, scientific knowledge and practical implementation knowledge to explore the development of local policy. And through combining these approaches, we developed an iterative framework that unearths explicit and implicit assumptions made by participants and how these relate to local policy implementation targeting inequalities in children and young people's health. In terms of key findings, while some participants refer to ethnicity and gender, our participants consistently foregrounded the importance of socioeconomic position in creating and maintaining inequalities in health. They highlighted significant inequalities both within the local area and also between the local area and the national average, and they linked these inequalities to an uneven distribution of the social determinants of health. Reducing socioeconomically patterned health inequalities was perceived as a key focus of local work, both within policy documentation and in discussion with key stakeholders. In terms of strategies for reducing inequalities, participants often referred to the need to take a whole systems approach to reducing poverty and improving services. This was often framed quite narrowly in terms of partnership working and organisational integration. Linked to this, participants discussed and policy documentation referred to the importance of a place-based community approach to improving the social determinants of health for people living in poorer areas. Lastly, barriers. The policy problem at a local level was perceived to be the need to do more with less under significant funding pressures of austerity Britain, and this was against a backdrop of increasing local poverty and deprivation. And despite clear efforts and intentions to reduce health inequality, improving outcomes within this climate was described as extremely challenging. Further, the situation was exacerbated by competitive, short-term funding structures which really mitigated against joined-up working. So what do we perceive to be the main implications of our study? Well, despite a firm commitment to taking a social determinants approach to reducing health inequalities at a local level, our study demonstrates that efforts are thwarted by the prevalence of poverty and reduced and disjointed funding, leading to cuts to public services. There is a clear need for more joined-up policy working at a national level, which takes into consideration regional disparities, allows for flexible interpretation, and involves actors across the system to address the different and interrelated social determinants of health. In particular, national government should develop a specific strategy targeting the social determinants of health within the context of proportionate universal funding. This is particularly pertinent in light of COVID-19, which has brought already widening health inequalities in England to the fore. Locally, policymakers should develop a health system which considers inequalities as unjust and puts the need to reduce inequalities at the core of all decision making. Key to this will be the development of a local definition of the term inequalities, which should be agreed by all partners. Further, local policymakers should continue to shift focus from downstream behavioural interventions and invest in programmes which focus on prevention. Such services should be based in communities and tailored to local need. Finally, and most importantly, local policymakers, alongside other child health advocates, should continue to press for investment and a commitment to reducing inequalities in child health at a national level. If you're interested in finding out more about our study and reading through the detail, then our paper is shortly going to be published in BMC Public Health, and I've left the citation for you there. Thank you.
Hi, I'm Kate Mason from the University of Liverpool. I'm going to briefly tell you about our study looking at childhood obesity in England and the impact of cuts to local government investment in early childhood services. Since 2010, central government grants to local authorities have been severely reduced under the UK government's austerity programme. This has led to dramatic cuts to many services, including Sure Start children's centres. These centres provide a range of community-based services that support children and their parents from conception through to age 4. Local authority expenditure on these services fell by 58% between 2010 and 2017, and these cuts have been deepest in more deprived areas. When the Sure Start scheme began in 1999, one of its explicit aims was to prevent childhood obesity. This figure shows the various ways that Sure Start children's centres might impact obesity risk, both directly through obesity prevention programs delivered in some centres, and indirectly by providing services that address the wider social determinants of child health, as well as services addressing perinatal risk factors for obesity. About 10% of kids are living with obesity by the time they start primary school. This percentage has remained fairly constant over recent decades, but what's of more concern are two things. Children from the most deprived areas in England are far more likely to be living with obesity compared with children from the least deprived areas, and this gap has been widening in recent years. We know that deprived areas have also borne the brunt of recent cuts to local government spending on Sure Start children's centres. So, given the many ways that children's centres might influence obesity risk, we wanted to know if the recent trends in spending and in obesity were linked. So we designed a longitudinal ecological study using publicly available data for local authorities in England. At the local authority level, there's variation in obesity prevalence and variation in the extent to which spending on Sure Start was cut. We took advantage of this to examine whether the prevalence of childhood obesity has increased more in those local authorities where Sure Start spending cuts were greater. We used data published by local authorities on their annual expenditure on the Sure Start scheme and data from the National Child Measurement Programme for children in the reception year of school when they're aged 4 or 5. We used a fixed effects panel regression model which allowed us to estimate the average change in obesity in a local authority when public spending levels change, independent of national trends in obesity. And it also allows us to control for differences between and within local authorities that might influence both spending levels and obesity prevalence over time. Our main finding was that child obesity prevalence tended to increase more in areas where Sure Start spending had been cut more. Every 10% cut in spending was associated with a relative increase in obesity prevalence of 0.34% the following year. This plot shows those results in more concrete terms. The red line shows the number of children with obesity that was actually observed, while the green dashed line shows the expected number of children with obesity if spending on Sure Start had been maintained at 2010 levels. So the gap between these two lines is what we interpret as the estimated effect of the spending cuts. Given the extent of the total cuts to Sure Start over the study period as a whole, we estimate that by 2017 there were an additional 4,500 children with obesity when they started school, over and above what would have been expected if spending had remained at 2010 levels. This relationship was similar regardless of how deprived an area was, but because more deprived areas were subject to far deeper spending cuts, in absolute terms we expect the impact on obesity prevalence will have been greater in those areas. So these findings suggest that continued disinvestment in Sure Start runs the risk of increasing child obesity prevalence, with a particular risk of further exacerbating inequalities. Importantly, the benefits of Sure Start go well beyond obesity. Several other studies have shown children's centres provide kids with a wide range of benefits for their health and development. So the impact of recent cuts to spending on Sure Start is likely to cover a range of outcomes beyond just the obesity impact suggested by our study. We know there's no single solution to the problem of childhood obesity. Lots of other research tells us that a multifaceted, system-wide approach is needed. What our study suggests is that reinvesting in Sure Start may be one effective part of a broader strategy to tackle childhood obesity.
Hello, my name is Sonia Saxena and I'm Professor of Primary Care at Imperial College London. The coronavirus pandemic has illustrated to all of us how closely our health is influenced by our social and physical environment. It's also thrown up stark health inequalities that existed even before the pandemic descended on us all and widened them. This has particularly influenced children and families. In the Harnessing Data for Child Health programme at Imperial, we take data from health, from educational settings and social care, and link that with multiple sources that tell us about the features of the changing environment that children live, play and learn in. And we use that to try to inform health policy and much wider policy. I'd like to share with you some of the examples of our work and the impacts that it has been having.
Hi, I'm Disha Venkatraman and I'm part of the Child Health Unit at Imperial College London. Here, I work on harnessing routinely collected data to improve child health. Through my PhD, I have used routinely available data in England to evaluate a popular school-based running program called the Daily Mile. The first step of this evaluation was to understand the profiles of primary schools registered to do the Daily Mile across England and assess whether it was being taken up in areas that could benefit from it the most. To do this, I created the first national schools database in the country. I linked data from a number of routinely collected datasets on health and education. These included the school census, various extracts of the National Pupil Database, the Active Lives Adult Survey, the Active Lives Children and Young People Survey, the National Child Measurement Programme, and data on registration to the Daily Mile. These datasets include information on the socio-demographic profiles of schools, such as the ethnicity and gender composition of a school, the educational attainment of children in a school, and other data, such as the proportion of children who are overweight or obese in a school. After doing some statistical analyses, we found that 1 in 5 primary schools in England were registered to do the Daily Mile, and schools in urban areas and those with a higher proportion of disadvantaged pupils were more likely to register. We also found that schools in areas of high need were more likely to register for the Daily Mile compared to those in areas of low need. This is just one example of how routinely collected datasets can be used to conduct cost-effective, real-world evaluations of public health interventions that can improve child health.
Hi, I'm Dr. Hannah Creese, and within the Harnessing Data to Improve Child Health work programme at Imperial, my work focuses on the current preschool wheeze and adolescent asthma. We summarised breaking evidence on risks and solutions for managing asthma in children during the COVID-19 pandemic. We found no strong evidence that children with asthma are more susceptible to COVID-19 infection. We found that if children with COVID-19 have a pre-existing medical condition, they are up to 10 times more likely to require an intensive care admission. However, the evidence for asthma is mixed. During the pandemic, there have been fewer severe asthma presentations in children to emergency departments. However, protracted homestay and suspension of elective reviews in primary care may have led to further widening of asthma inequalities. We conducted patient and public involvement to hear parental experiences of healthcare for recurrent wheeze before and during the COVID-19 pandemic. Research themes important to parents included the impacts of early preventative care, changes in access to healthcare during the pandemic, and the impact of air quality. Also, how recurrent wheeze may impact on language, social, behavioural, and mental health outcomes in children. We plan to investigate these impacts in a nationally representative birth cohort of children in the Clinical Practice Research Data Link. Finally, in a causal mediation analysis, we assessed how blocks of perinatal characteristics measured at 9 months and environmental risk factors measured at 3 years mediated the total effect of socioeconomic circumstances in early life on persistent asthma at age 14 in the UK Millennium Cohort Study. There was a clear social gradient in persistent asthma. Overall, just under 60% of the total effect of socioeconomic circumstances on risk of persistent asthma in adolescents was mediated by perinatal and environmental characteristics. So, from all of us in the Harnessing Data to Improve Child Health Work programme at Imperial, thank you for listening.
Thank you so much for tuning in. My name is Pia Hardlid and I'm an epidemiologist. I lead the Children and Young People's Work Package 2 project at University College London. And here at UCL, we are primarily working on using national birth cohort data for child public health research. So I will just talk you through what I mean by that. So these national birth cohorts are data sets that we have developed where we follow all children born in England during a particular time period via linkage from their routinely collected birth registration and NHS birth notification data via linked hospital admission records and death records data. And then within these data sets, it is possible to link the baby's longitudinal health data to their mother's longitudinal hospital admission data via the maternity record. And of course, a mother might have more than one child, and so it's also possible to link children to their siblings within these national data sets. And further, we are linking to Census 2011 data, which has got where we link the mothers to their census records. So that contains very detailed data on socioeconomic circumstances, or as well as housing and migration history, for example. So because these are national data sets, they contain data on all children born in England. We currently are working with a data set that contains data for 6.7 million children, of which 1.3 million children whose mother's data has been linked to census data. So I just wanted to show you some results from our project. So for our first piece of work, we used openly available stillbirth and infant mortality data to look at trends in stillbirth, perinatal and infant mortality by deprivation level in England. And as you can see on this slide here, the grey lines are stillbirth rates over time, and the black lines are infant mortality rates over time. You can see that in the most and the least deprived areas, both infant mortality and stillbirth rates have declined throughout this study period. However, there has not been a narrowing of these rates in between the richest 20% of areas in England and the 20% of the poorest areas in England. So the social inequalities in both infant mortality and stillbirth still remain. So another thing we have examined using a national birth cohort for England is to look at geographical variation in infant accident and emergency attendances and hospital admissions. So this plot here shows you accident and emergency attendance rates by 1,000 child years for each local authority in England. So those are the dots, according to the number of births in each local authority. And there's, in fact, as you can see on this graph, there's a 6-fold variation in accident and emergency attendance rates across England, with the highest rates here tend to be in the northeast of England and London, and the lowest rates tend to be in the southwest of England. If we had been looking at infant admissions to hospital, then London would have some of the lowest rates in the whole country. And we've also found that this is a forest plot showing incidence rate ratios for the risk of infant accident and emergency attendance, and we found that factors such as being born too early, so premature birth, or being born with a congenital anomaly are strongly predictive of accident and emergency attendance in babies. What we're doing now is that we're looking at parental migration status and preventable hospital admissions in children. And here we are looking to use that English national birth cohort that I told you about that's been linked to 2011 census data. And so here we are looking at how planned and emergency hospital admission rates in children born in England vary according to the mother's and the father's country and region of birth, and also to what extent are any differences in rates based on parental migration status related to things like how long the parents have lived in the UK and how long they have and the knowledge of English. So these are things that we're working on at the moment. And I just want to thank the School for Public Health Research for funding, and all my fantastic colleagues at UCL, Liverpool and Imperial. I want to thank parents from the National Children's Bureau Parents Advisory Group who've provided input to this project, and all the children whose depersonalised NHS data were used. And thank you very much for listening.
Mapping the child health system at a local level to reduce child health inequalities. I'm Trish Jessamine, presenting for the next 5 minutes. My fellow research team members are there on the screen in front of you from the Universities of Bristol and Sheffield. The aim of the study was to scope and develop a system map of factors that contribute to child health inequalities amongst children and young people at a local level. By local, we mean the geography of a local authority area. We all know that children and young people in the UK have worse health outcomes than in many similar Western countries, and that these child health inequalities are persistent and increasing. Child health inequalities are complex. They are created, maintained, and exacerbated through multiple and related pathways. One way to understand and work with this complexity is to apply a systems-based approach to identifying the contributors to child health inequalities at the local level, in the hope that this will inform effective interventions in the system to reduce them. Fieldwork for the study was undertaken throughout 2019, pre-pandemic. We worked with 2 contrasting local authority areas, one an urban setting and the other a more rural 2-tier authority, to develop initial area-specific maps. Briefly, in each area, we carried out qualitative interviews with senior decision makers with responsibility for child health, and then group mapping workshops where we asked the 2 questions that you see on the screen. We had a wide range of stakeholders at these workshops, including professional staff from the local authority, NHS and CCG, children, young people, and their parents and carers. We then compared and contrasted the 2 locally specific maps, removing factors that seemed very localised and combining the remaining factors to develop a more generic version that might be applied to any English local authority area. This was sent out for consultation via 2 rounds of an online survey with experts in system mapping and experts in child health from both a policy and a practice perspective. This is the final system map. It has 125 factors arranged across 6 domains of influence. You can see these across the top of the map, and the factors are colour-coded. They include the physical environment, governance, economic factors, social factors, and local services, and the personal domain. There isn't time to go through the map in detail, but I will show you a couple of domains in isolation. What I hope is obvious from seeing the whole map is just how interconnected the factors and the domains are. The service domain represents the availability and delivery of services provided by the public, private and third sectors at the local area level, which impact on child health outcomes. The 3 factors with most links to those in other domains are unsurprisingly health, social care and education, but the range of service types emerging from the workshops was much wider than these core 3. A second example is the social domain. Factors here are related to people around children, young people who influence their health behaviours and outcomes. These split broadly across parents and families, peer groups, and local communities. The online consultation respondents particularly wanted to represent the wider climate that all areas have to operate in. So on the outside of the map, we've listed determinants that heavily influence child health inequalities, but are outside the immediate control of local agencies. Had we done this in 2020, you'd probably also see global pandemics on there. So there's the map in full again, showing the 6 domains, how all the factors interrelate, and alongside the list of factors outside the system, and also subpopulations that might be at risk of poor health outcomes. The first thing we concluded from this is that mapping the determinants of child health inequalities for all populations of children and young people from birth to 25 years and for all health outcomes, not just a single issue such as obesity, is possible. People recognise that there is a local system that impacts on child health inequalities, and we're able to engage in group mapping to identify what it might look like. Obviously, the map is busy, it's complex, it's qualitative, so there's no indications of direction or strength between the factors on the map. And again, the fieldwork was carried out pre-COVID, and things already look very different now. However, as we emerge from the immediate crisis, it may be an opportune time for local areas faced with extremely stretched resources to think again about how services for children and young people are delivered and how health inequalities are addressed. It's our hope that we've demonstrated by mapping the whole system that single programmes or single interventions are unlikely to impact on the complex and dynamic issue of child health inequalities. Interventions at a systems level are more likely to be required. We pose a couple of questions here that perhaps you might want to pick up on during the discussion. How might the map be used to support discourse with partners in the public around reducing child health inequalities? And how might it be used to inform potential strategies for intervention or action? There is more information about the study available on the SPHR website, including a paper that we published on this earlier this year. Thank you for listening.